Assalamualaikum. I'm Dr. Itisham Shoaib, going to present a case. A 55-year-old man with protracted vomiting and generalized weakness. Chief complaint: severe protracted vomiting for 1 month and generalized weakness for same duration. Salient feature: a Mr. X, 55 years old, non-smoker, non-diabetic, Muslim, and non-hypothyroid person, hailing from Pirozpur, and got admitted in DMCS with the complaints of non-projectile protracted vomiting for 1 month and generalized weakness for same duration. So there is two main problem: number one, vomiting, and number two, generalized weakness. Regarding vomiting, if we have to ask some question regarding vomiting, if we found a patient, first question is there any relation to meals or timing, such as early morning vomiting or late evening vomiting? In case of early morning vomiting, it signifies the raised intracranial pressure. If it is related to meals, then sometimes it relates with gastrointestinal disorder. Is there associated any symptoms such as dyspepsia, abdominal pain, whether they are relieved by vomiting? If there is any intestinal obstruction, it is relieved by vomiting. Is the vomiting is bile stain, that is green color, or blood stain, that is hemoptysis or hematomesis melena? Is there it is hematomesis melena? Associated weight loss and patient's medications. We have to ask about medications, weight loss, color of vomiters, associated symptom, and timing of vomiting. There is some clues: nausea and vomiting, particularly with abdominal pain or discomfort, suggest upper gastrointestinal disorder. If a patient has abdominal pain or abdominal discomfort and associated with nausea or vomiting, then we should look for upper gastrointestinal disorder. And dyspepsia may cause nausea but never cause vomiting. Vomiting is common in case of gastroenteritis, cholecystitis, pancreatitis, and hepatitis. There is a history of nausea followed by vomiting in case of gastroenteritis, cholecystitis, pancreatitis, and hepatitis. But in case of raised intracranial pressure, there is no warning feature of nausea. Sometimes severe pain may precipitate vomiting. Pain is the predominant feature in case of renal colic, biliary colic, or myocardial infarction. Some psychological cause, that is anorexia nervosa, bulimia nervosa, can cause self-induced vomiting. Non-GIT causes of nausea and vomiting. Always in case of vomiting, we will have asked for drugs cause, such as if patient has taken any history of taking NSAIDs, opioid, digoxin, such as antibiotic, antidepressant, and alcohol. Is there any history of UTI? Is there any history of burning micturition, lower abdominal pain? Patient is diabetic or non-diabetic. Diabetic ketoacidosis may present with vomiting. Any history of CKD? CKD patients, CKD patient can present with nausea and vomiting. Liver failure. A patient has fever, jaundice, and vomiting or nausea and difficult to eat any content. Then we should look for hepatitis. Hypercalcemia. Addison's disease. If patient has hypotension, then Addison's disease could be a cause. Raised intracranial pressure, migraine, patient with migraine and vestibular disorder. Vomiting with headache, vomiting with photophobia, phonophobia, we should have to look for migraine. And vomiting with vertigo, we should look for vestibular disorder. Regarding this, now in our patient, The vomitus contain mixed, অর্থাৎ that means both undigested and digested food materials 30 to 40 times in a day, দিনে 30 থেকে 40 বারের মতো হচ্ছে, approximately 50 to 60 ml in amount, not bile stain, non-contain any blood, not self-induced, partially subsided by antiemetic. So there is non-bile stain. If obstruction is distal to pylorus, then bile stain vomitus is occur. Not contained any blood, that means hematomesis. In case of CLD, hematomesis, blood stained vomitus can be found. Not self-induced, that means there is no psychogenic disorder, that is bulimia nervosa, and partially subsided by antiemetic medication. He complains of loss of appetite as well as, তার ক্ষুধা মন্দা হয়েছে, but not associated with any abdominal pain. অ্যাবডোমিনাল পেইন থাকলে আমরা চিন্তা করি আপার জিআইডি ডিসঅর্ডার আছে কিনা। অ্যাবডোমিনাল পেইন অর ডিসকমফোর্ট থাকলে, অর্থাৎ তার দেয়ার ইজ কোনো পেপটিক আলসার ডিজিজ, গ্যাস্ট্রিক ক্যান্সার, গ্যাস্ট্রোপ্যারিসিস. No diurnal variation. In case of diurnal variation, early morning vomiting or late evening vomiting is associated with raised intracranial pressure, not related to meals, that means PUD excluded. Denies any history of taking drugs other than antiemetics, so drugs causes are excluded. So non-GIT causes including drugs, including CNS problem, that is raised ICP, abdominal pain, that means UTI, hepatitis are excluded here. He has been suffering from generalized weakness and dizziness associated with vomiting. Vomiting এর সাথে সাথে generalized weakness and dizziness আছে. Dizziness is more marked in standing position, যখন দাঁড়াচ্ছে তখন অনেক বেশি হচ্ছে. He also complained of cold intolerance and constipation. We know that 3C: cold intolerance, constipation and changes in voice. এই তিনটা একসাথে থাকলে this goes favor of hypothyroidism. So patient has cold intolerance and constipations, so there may be hypothyroidism. On query, she mentioned that he had loss of libido, complained of weight loss, but that is not significant weight loss. But patient denies any history of fever, কোনো তার জ্বর নাই, headache, blurring of vision, dysuria, excessive sweating and palpitation. So as there is no fever, so UTI, hepatitis, any kind of infection, that is cholecystitis, pancreatitis and in appendicitis are excluded. There is no history of headache or blurring of vision, that means raised ICP is excluded. Dysuria, UTI is excluded. Excessive sweating and palpitation. Any pituitary disorder and central nervous system disorder are excluded. But we found a new symptom, that is loss of libido. He is diagnosed a case of hypothyroidism and levothyroxine, and taking levothyroxine for 1 year. He had history of 2 times admissions for severe vomiting followed by unconsciousness in 2023. On query, he had a history of steroid intake for 2 weeks, that is difluzacort, due to his knee pain 1 year back. So আমরা চিন্তা করছিলাম পেশেন্টের হাইপোথাইরয়েডিজম আছে, দ্যাট ইজ প্রুভড বাই লিভোথাইরক্সিন থেরাপি। বাট পেশেন্টের 15 দিন ইন্টারভ্যালে 2বার অ্যাডমিশনের হিস্ট্রি আছে অ্যান্ড ফলোড বাই vomiting and unconsciousness, and she has given a history of taking steroid, but no history of previous tuberculosis and contact with TB patient. Abdominal trauma, that is abdominal কোনো সার্জারি নাই, abdominal trauma নাই। আমরা টিউবারক্লোসিস কেন চিন্তা করছি? বিকজ when patient presents with vomiting, with generalized weakness for a long time, that is chronic vomiting, then we will have to search for other causes. Is there any history of tuberculosis is important? Is there any history of abdominal surgery such as bilateral adrenectomy, unprotected sexual exposure, is there any history of HIV, or intravascular drug abuse. Everything is related to vomiting. She was allergic to pork and beef, immunized as per EPI schedule. No family member has such type of illness. On general examination, patient was pale, that means patient is anemic. Average body build, decubitus on lying position. Mildly anemic and moderate dehydration. Important finding is postural hypotension. If it is evidenced by 100/60 mm on lying position, but on standing position that is 80/50 অর্থাৎ 20/10 কমছে, systolic 20 and diastolic 10. Pulse is regular, beat per minute. There are several hypopigmented spots. Another positive findings is several hypopigmented spots present on lower back and both thigh without any buccal and palmar crease pigmentation, or there is no pigmentation but no hyperpigmented disorder, but there is some hypopigmented disorder. His axillary and pubic hair are reduced. There is no history of jaundice, cyanosis, clubbing, koilonychia, leukonychia, edema and bony tenderness. No lymph node is enlarged. Thyroid gland is not palpable. JVP was not raised. এই কথাগুলো আমরা কেন বলেছি? পেশেন্টের সিএলডি আপনাকে এক্সক্লুড করতে হবে. উইল হ্যাভ টু এক্সক্লুড সিএলডি. উইল হ্যাভ টু exclude CLD for jaundice and leukonychia is important, and low lymph node is enlarged because we will have to exclude lymphoma, as well as systemic investigation of other system reveals no significant abnormality. So our problem list is patient has vomiting for 1 month associated with generalized weakness, loss of libido, reduced axillary and pubic hair, and back a hypopigmented rash. So we can think about, from this history we can think about adrenal insufficiency. The thing is, in case of adrenal insufficiency, there is hyperpigmentation. There is hyperpigmentation due to ACTH excess. But here there is hypopigmented lesions. There is hypopigmented lesions. So our problem list: 55-year hypothyroid man, vomiting, generalized weakness, loss of libido, hypopigmentation and reduced hair. So what is our professional diagnosis? We think adrenal insufficiency. Adrenal insufficiency are two types, mainly secondary adrenal insufficiency or primary adrenal insufficiency. Primary adrenal insufficiency is called Addison's disease. Primary adrenal insufficiency ke Addison's disease বলা হয়. Addison's disease most common cause হচ্ছে অটোইমিউনো কজ হতে পারে. Then APS, autoimmune polyendocrine syndrome, একই সাথে অনেকগুলো endocrine problem. Tuberculosis, for this reason we will have to exclude the history of tuberculosis or contact any patient of tuberculosis. HIV, for this reason we should have to take history of any sexual exposure. We also take history of any abdominal trauma and abdominal surgery, and there is no lymphadenopathy, so lymphoma is also excluded. So there is, in case of adrenal insufficiency, it may be primary or secondary, right? So in case of our patient, if we think that it's primary adrenal insufficiency, then it may be Addison's disease. So regarding glucocorticoid deficiency, if glucocorticoid deficiency is found, then patient may have anorexia, nausea, vomiting. So patient have history of vomiting and postural hypotension. We found this due to glucocorticoid deficiency. Another is due to mineralocorticoid deficiency, patient may present with shock or hypotension, but there is no history of shock, but patient has history of admission in SBMC due to unconsciousness. For this reason, maybe electrolyte imbalance, patient got admitted in medical college hospital. And due to adrenal androgen insufficiency, patient has androgen deficiency, patient has reduced libido and reduced axillary and pubic hair. But if it is Addison's disease, that means primary adrenal insufficiency, then ACTH will be high, and if ACTH will be high, then there is hyperpigmentation. But we found the hypopigmented area. Another is if ACTH is high, then we can found hyperpigmented area in sun exposed area, palmar crease, mucous membrane, recent scar, but we don't found this. So we can think about there is something else with Addison's disease, as there is features of adrenal insufficiency with hypopigmented area. For this reason, we think about autoimmunopolyendocrine syndrome, that is polyendocrine syndromes, because in case of polyendocrine syndrome type 2, there is Addison's disease, there is primary hypogonadism, there is primary hypothyroidism and vitiligo. So our patient has primary hypothyroidism, already on levothyroxine, features of Addison's disease, both glucocorticoid, mineralocorticoid and adrenal androgen deficiency, primary hypogonadism, loss of libido and hypopigmented area, that is vitiligo. So our provisional diagnosis is autoimmunopolyendocrine syndrome type 2. We have differential diagnosis, that is hypothyroidism with secondary adrenal insufficiency, that is secondary adrenal insufficiency due to steroid withdrawal or secondary adrenal insufficiency due to hypopituitarism. So we think that our provisional diagnosis is APS, and we have differentials of secondary, that is withdrawal of ACTH, and number 2 is panhypopituitarism. In case of panhypopituitarism, all the hormones are reduced. So growth hormone reduced, patient features of lethargy, gonadotropin reduced, patient features of lethargy, amenorrhea, loss of hair and loss of libido. Due to ACTH deficiency, secondary adrenal insufficiency, and TSH deficiency, primary hypothyroidism, autoimmunohyperthyroidism hote pare. So this can be explained in our patient by hypopituitarism. Next, we will have to go for investigation to confirm the diagnosis. Investigation profile reveals that there is total count, there is anemia, and total count and neutrophil is low. We know that glucocorticoid pain বাড়ায়, pain বাড়ে and বেল কমে যায় in case of glucocorticoid. So if there is deficiency of glucocorticoid, then basophil count will be raised, eosinophil count will be raised, and lymphocyte count will be raised. In contrast, the neutrophil count will be low. So glucocorticoid deficiency, neutrophil count will be low, there is neutropenia. So neutropenia signifies the glucocorticoid deficiency. In case of glucocorticoid insufficiency, there is hypoglycemia is common, but we found glucose within normal level. Serum creatinine, uric acid, bilirubin and liver function tests are within normal level. Urinary is normal level, and we found that there is history of hyponatremia. There is history of recurrent hyponatremia. In case of adrenal insufficiency, there is hyperkalemia. There is hyperkalemia, but it is not universal. It is not universal. As our patient has vomiting, so there is reduced potassium. Otherwise, in case of adrenal insufficiency, there is hyponatremia and hyperkalemia. But due to vomiting, potassium may be reduced. Then we go for urinary electrolytes. Urinary sodium 390, অর্থাৎ more than 30, that signifies that it is renal loss. TSH is high. At first it is 55. FT4 is low. Serum cortisol level 63. That means serum cortisol level is low. In case of adrenal insufficiency, serum cortisol level will be low. If ACTH is high, then it will be primary adrenal insufficiency. If ACTH is low, then it will be secondary adrenal insufficiency. Here we found that ACTH is low, so we can think about it's a case of secondary adrenal insufficiency. And in case of secondary, there are two reasons. Most common is withdrawal of suppressive glucocorticoid therapy, and another is panhypopituitarism. For this reason, we go for another hormonal assay, that is growth hormone, FSH, LH, all are low. Anti-TPO antibody is high, that signifies that it's an autoimmunohypothyroidism. Serum calcium, albumin, phosphate, PTH, all are in normal level. Another hormone, that is testosterone, prolactin, all are in normal range. We also go for C-peptide because we know that type 2 APS has association with type 1 diabetes mellitus. So we go for C-peptide level also. ECG, X-ray, ultrasound, endoscopy, all are normal. As ACTH is low, we have a differential of panhypopituitarism. For this reason, dynamic MRI of pituitary and hypothalamus was also done, and result was normal MRI findings. So secondary adrenal insufficiency, that means ACTH is low, there is two reasons: withdrawal of suppressive glucocorticoid therapy, another is panhypopituitarism. As normal MRI report, so we have only one option, that is withdrawal of glucocorticoid. We also give an endocrine referral. They has give an answer, and it signifies that it's an autoimmunohypothyroidism with adrenal insufficiency. Adrenal insufficiency may be due to withdrawal of steroid. For adrenal insufficiency, please add hydrocortisone and start dose, and in 6 hourly, then gradually tapering the dose. Start levothyroxine 3 days after the hydrocortisone therapy. It's very much important. In case of secondary ACTH deficiency, in case of secondary adrenal insufficiency, always steroid replacement is first, then thyroid replacement. Never replace thyroid before steroid replacement. It will cause adrenal insufficiency, adrenal in crisis. So our confirmatory diagnosis is autoimmunothyroidism. autoimmune hypothyroidism with secondary adrenal insufficiency due to steroid withdrawal. We treated the patient with fluid hypothyroidism জন্য thyroxine and hydrocortisone. Patient's condition was improved after getting hydrocortisone. Patient was discharged with levothyroxine with tapering dose of steroid and visit 1 month after. This is all for our lecture, but we have some discussion regarding adrenal insufficiency. Now I am talking about adrenal insufficiency. The causes of adrenal insufficiency either secondary, that is withdrawal of suppressive glucocorticoid therapy, or hypothalamic or pituitary disorder, that is panhypopituitarism, and primary, that is called primary adrenal insufficiency, is called Addison disease. Some autoimmune cause, there is some APS cause, that is polyglandular syndrome, tuberculosis, HIV, metastatic carcinoma, lymphoma, amyloidosis, hemochromatosis, and histoplasmosis is also important. Some drugs regarding mitaropon, ketoconazole, and etomitate. Clinical features of adrenal insufficiency, very much important. If patient has secondary adrenal insufficiency, that means the problem is in pituitary, then you will found glucocorticoid deficiency and adrenal deficiency. As there is pituitary problem, so there is no ACTH, and mineralocorticoid has no control from pituitary. Mineralocorticoid has no control, that is zona glomerulosa is not controlled by pituitary. So zona glomerulosa is not affected in case of pituitary problem. In case of secondary problem, same as hypopituitarism, that is problem is in your brain, so glucocorticoid deficiency will be found and adrenal androgen deficiency will found. As there is pituitary problem, so there is no ACTH. Mineralocorticoid is not affected. But in case of Addison's disease, there is problem is in gland, so there is glucocorticoid deficiency, androgen deficiency, mineralocorticoid deficiency, and pituitary is intact, so pituitary try to increase the level. For this reason ACTH is excess, there is ACTH excess. And features of glucocorticoid excess, you will find anorexia, nausea, vomiting, weight loss, and hyponatremia, hypercalcemia. Mineralocorticoid deficiency, there is hyponatremia and hyperkalemia. And in case of ACTH excess, there is hyperpigmentation, and due to androgen deficiency, there is loss of libido. So if there is primary adrenal insufficiency, you will find both of them, features of glucocorticoid deficiency, features of mineralocorticoid deficiency, there is hypopigmentation and reduced libido. But in case of panhypopituitarism, you can find features of glucocorticoid deficiency and features of androgen excess, but there is no pigmentation, there is no features of mineralocorticoid excess. This is very basic. The patient should be considered in a patient with hyponatremia in absence of symptom. If a patient presents with recurrent episodes of hyponatremia, either it is dilutional or depletional, you will have to search for Addison's adrenal insufficiency. So adrenal insufficiency are two types, such as primary and secondary. Secondary means there is problem in brain, and primary means there is problem is in adrenal gland. How can we differentiate between primary and secondary? Weight loss, GI upset, postural hypertension is common both in primary and secondary. But in case of primary, there is hyperpigmentation due to rise of ACTS. There is excess ACTS এর জন্য আপনি প্রাইমারিতে হাইপারপিগমেন্টেশন পাবেন, বাট সেকেন্ডারিতে আপনি প্যালোর পাবেন। এটা দিয়ে আপনি প্রাইমারি সেকেন্ডারি আলাদা করতে পারবেন। হাইপোটেনশন অ্যান্ড শক. Hypotension and shock is due to mineralocorticoid insufficiency, so it is more common in primary. Weight loss is uniform in features of primary adrenal insufficiency. Always weight loss পাবেন। In contrast, there is secondary, there is Cushing-Goid phase, because there is most common cause is withdrawal of suppressive glucocorticoid therapy. In case of Addison's is a autoimmune disease, so features of other immunoendocrinopathies such as thyroid disease, such as vitiligo, celiac disease, type 1 diabetes, tuberculosis can be associated. In case of secondary, other pituitary hormone deficiency, growth hormone, follicular hormone, TSH hormone, other pituitary deficiency can be found. There is normocytic normochromic anemia, neutropenia, eosinophilia, lymphocytosis, hypercalcemia, and hyponatremia. In our patient, we have found neutropenia and normocytic normochromic anemia. Hyperkalemia is not always present, but hyperkalemia is common. It will found in primary adrenal insufficiency, that is Addison's disease. To confirm the Addison's adrenal insufficiency, we will do for short synaptin test. It will both positive in primary and secondary. Short synaptin test আমরা করি কেন? ডায়াগনোজ প্রাইমারি অর সেকেন্ডারি অ্যাড্রেনাল ইনসাফিসিয়েন্সি। তাহলে আমরা প্রাইমারি এবং সেকেন্ডারিকে কনফার্ম করব শর্ট সিনাপ্টিন টেস্টের মাধ্যমে। দেন প্রাইমারি এবং সেকেন্ডারির মধ্যে পার্থক্য করব কীভাবে? প্রাইমারি এবং সেকেন্ডারির মধ্যে পার্থক্য করার জন্য আমাদের কয়েকটা টেস্ট আছে, স্পেশাল এসিটিএস করা হয়। এসিটিএস যদি লো থাকে তাহলে সেকেন্ডারি, এসিটিএস যদি বেশি থাকে তাহলে প্রাইমারি। এছাড়া আমরা হাই রেনিন এবং লো অ্যান্ডোস্টেরন পাই প্রাইমারির ক্ষেত্রে। মিনারেলোকর্টিকয়েডের ইফেক্টটা আমরা প্রাইমারিতে পাই। আমরা যদি প্রাইমারি কজ পাই তখন আমরা কী ইনভেস্টিগেশন করব? প্রাইমারি ইনভেস্টিগেশন করলে আমরা সিটি অফ অ্যাড্রেনাল গ্ল্যান্ড করতে পারি। অ্যাড্রেনাল গ্ল্যান্ডে অ্যাট্রোপি থাকে, বাইল্যাটারাল অ্যাড্রেনাল এনলার্জমেন্ট থাকে, অনেক সময় মেটাস্টাসিস, লিম্ফোমা, সার্কোইডোসিস, এনি ইনফিলট্রেটিভ ডিসঅর্ডার, এইচআইভি, টিউবারকুলোসিস, এগুলো দেখতে পারি। আর যদি সেকেন্ডারি চিন্তা করি, প্রথম কথা হচ্ছে তার হিস্ট্রি অফ স্টেরয়েড, 2 নম্বর কথা হচ্ছে এমআরআই করলে ম্যাক্রোলিনোমা পেতে পারি অথবা এমটিসেলা পেতে পারি। প্রাইমারি যদি হয়, প্রাইমারি ট্রিটমেন্ট গ্লুকোকর্টিকয়েডের সাথে মিনারেলোকর্টিকয়েড দিতে হবে, অ্যাজ দেয়ার ইজ প্রবলেম ইন গ্ল্যান্ড, মিনারেলোকর্টিকয়েড ডেফিসিয়েন্সি রয়েছে। বাট ইন কেস অফ সেকেন্ডারি, অনলি গ্লুকোকর্টিকয়েড ইজ এনাফ। Glucocorticoid insufficiency. So adrenal insufficiency, to measure adrenal insufficiency, we can measure glucocorticoid, we can measure mineralocorticoid, we can access the adrenal androgen. To measure glucocorticoid, random measurement of plasma cortisol cannot be used to confirm. Random আমরা করতে পারি না। তবে যদি পেশেন্ট আমাদের কাছে আসে, আমরা যদি 500-র উপরে থাকে ন্যানোমোল পার গ্রাম, তাহলে আমরা অ্যাড্রেনাল ইনসাফিসিয়েন্সি এক্সক্লুড করতে পারি। আদারওয়াইজ আমাদের আর্লি মর্নিং করতে হবে। আর আর্লি মর্নিং যদি আপনার 11-র বেশি থাকে তাহলে হচ্ছে আনলাইকলি, আর 3-এর বেশি থাকলে, 3-এর কম থাকলে ভেরি লাইকলি। এগুলো সবই হচ্ছে র্যান্ডম স্যাম্পলিং। আর যদি কনফার্ম করতে হয় তাহলে কিন্তু শর্ট সিনাপ্টিন টেস্ট করতে হয়, তাহলে সেটা কনফার্মেটরি আসবে। ট্রিটমেন্ট আমরা ইনজেক্টেবল দিতে পারি। ইনজেক্টেবলের পরবর্তীতে আমরা ওরাল হাইড্রোকর্টিসন 15 to 20 মিলিগ্রাম ইন ডিভাইডেড ডোজ, অ্যান্ড ঘুমের থেকে উঠে 10 মিলিগ্রাম আর 5 মিলিগ্রাম বিকালের দিকে নেবে। ফিজিওলজিক্যাল রিপ্লেসমেন্ট এটা কখনো কুশিং-গয়েড সিনড্রোম করবে না। পেশেন্টের ফলো আপ করবো, পেশেন্টের ওয়েলবিং হবে অ্যান্ড পেশেন্টের ওয়েটটা বাড়বে যেহেতু কম ছিল। ফ্লুরোকর্টিসন, আমরা মিনারেলকর্টিকয়েড ডেফিসিয়েন্সির জন্য ফ্লুরোকর্টিসন দিব। ফ্লুরোকর্টিসন দিলে পেশেন্টের ফলো আপ করতে হয় ব্লাড প্রেশার, ইলেকট্রোলাইট অ্যান্ড প্লাজমা রেনিন লেভেল। একজন পেশেন্টে আপনি গ্লুকোকর্টিকয়েড থেরাপি দিলে কী কী অ্যাডভাইস দিতে হবে বলতে হবে। যদি আপনার কোনো ইন্টারকারেন্ট ইলনেস হয়, যেমন জ্বর আসে, ঠান্ডা কাশি হয়, তাহলে হাইড্রোকর্টিসন যদি একটা খান তার জন্য 2টা করে খেতে হবে, একটা ডবলটা ডোজ। যে কোনো মেজর সার্জারি, মাইনর সার্জারির আগে ডোজ বাড়াতে হবে। ইফ পেশেন্ট হ্যাজ ভমিটিং দেন প্যারেন্টাল হাইড্রোকর্টিসন দিতে হবে। পেশেন্ট শুড ক্যারি এ স্টেরয়েড কার্ড। Sometimes patient may develop adrenal crisis. Adrenal crisis we can diagnose as a case of circulatory shock with severe hypotension, hyponatremia, hyperkalemia, hypoglycemia precipitated by intercurrent disease, surgery or infection. Random cortisol level less than 550, 550-এর কম থাকবে। আমাদের র্যান্ডম কর্টিসল নিতে না পারলেও অ্যাজ সুন অ্যাজ পসিবল পেশেন্টের কারেক্ট ভলিউম ডেপ্রিসিয়েশন, রিপ্লেস গ্লুকোকর্টিকয়েড, কারেক্ট আনাদার মেটাবলিক অ্যাবনর্মালিটি অ্যান্ড আইডেন্টিফাই অ্যান্ড ট্রিট দ্য কজ, এটাই করতে হবে। দিস ইজ অল ফর টুডেস। থ্যাংক ইউ ভেরি মাচ।